Good morning. This chapter of Schwartz is divided into 5 subtopics: the trachea, the lung, the chest wall, the mediastinum, and the pleura. We shall tackle each one by one, just the um, important ones, the ones that fit at your level. So let's start with the trachea. The trachea is composed of cartilaginous and membranous portions, beginning with the cricoid cartilage, which is the first complete cartilaginous ring of the airway. The subglottic space is the narrowest part of the trachea, with an internal diameter of 2 centimeters. The rest of the trachea measures 10 to 13 centimeters long, with 18 to 22 rings and an internal diameter of 2.3 centimeters. Bronchoscopically, the tracheal rings are visible as C-shaped hyaline cartilaginous structures that provide rigidity to the anterior and lateral tracheal walls. The open ends are connected by the trachealis smooth muscle and are covered in a dense band of connective tissue called the perichondrium. So the blood supply is vast and as follows, the ones seen here in your um, PowerPoint presentation. So inferior thyroid, subclavian, supreme intercostal, and the rest. All of these are interconnected along the lateral surface of the trachea. So let's proceed with tracheal injury. Tracheal injury can result from a variety of causes, including inhalation of smoke or toxic fumes, aspiration of liquids or solids, endotracheal intubation, blunt and penetrating trauma, and iatrogenic injury. Management of smoke or toxic fume inhalation, as well as liquid aspiration, is commonly supportive. For ET intubation, the most common cause of injury is overinflation of the ET cuff. This causes ischemia of the contiguous airway wall in as short as 4 hours. Prolonged overinflation can lead to scarring and eventually stenosis. Tracheal stenosis after tracheostomy can occur in 3 to 12% of cases. Stridor and dyspnea on exertion are the primary symptoms of tracheal stenosis, and the time of onset of symptoms after extubation or tracheostomy decannulation is usually 2 to 12 weeks, or it can be as long as 1 to 2 years later. Frequently, patients are misdiagnosed as having asthma or bronchitis, and treatment for such illnesses can persist for some time before the correct diagnosis is discovered. A comprehensive bronchoscopic evaluation is critical in the initial phase of evaluation and management of tracheal stenosis. We have to determine the stenosis length, location, the distance between the vocal cords and the proximal stenosis, as well as the distance from the distal aspect to the major carina. Most intubation injuries are located in the upper third of the trachea, so resection can be done involving 2 to 4 centimeters of trachea for benign stenosis. For those patients in whom tracheal resection is not possible, or the patient has severe comorbidities or very long stenosis, ET stenting or endotracheal stenting may be employed, typically using silicone T-tubes. Tracheal replacement is evolving as an option for management of tracheal stenosis, but it is still in its early phase. Let's now proceed with tracheal fistulas. There are actually two types of tracheal fistulas. We have the tracheoinnominate artery fistula and the esophageal fistula. So let's talk first about the tracheoinnominate fistula. It has two main causes. The first one is the low placement of a tracheostomy, and the next one is hyperinflation of the tracheal cuff. The placement of tracheostomy should be through the second to fourth tracheal rings. Remember this, second to tracheal rings. Because if placed below, the inner curve of the tracheostomy cannula will be positioned to exert pressure on the posterior aspect of the innominate artery, leading to arterial erosion. Similarly, hyperinflation of the tracheal cuff will cause ischemic injury to the anterior airway and subsequent erosion into the artery. Clinically, innominate artery fistula presents with bleeding, and when this happens, the cuff may be hyperinflated temporarily to occlude the arterial injury as seen in the picture. So here, patients should be brought back to the operating room and an orotracheal tube ready in place if needed. If unsuccessful, digital control should be done after the tracheostomy incision is widened. A third option would be to use a bronchoscope to place pressure on the bleeding site. Lastly, emergent surgical resection of the involved segment of artery is performed, usually without reconstruction. Next, we have the tracheoesophageal fistula. TEFs occur primarily in patients receiving prolonged mechanical ventilator support, concomitant with an indwelling nasogastric tube. Cuff compression of the membranous trachea against the nasogastric tube leads to airway and esophageal injury and fistula development. PE may show saliva and gastric contents or tube feedings on airway suctioning. Bronchoscopy allows visualization of the fistula at the cuff site, while endoscopy may demonstrate cuff of the ET tube in the esophagus. Treatment, first and foremost, requires removing tubes from the esophagus and weaning the patient from the ventilator. The cuff of the ET tube should be placed below the fistula, avoiding overinflation. To minimize aspiration, a gastrostomy tube should be placed to restrict decompression to prevent reflux, and a jejunostomy tube for feeding. If aspiration persists, esophageal diversion with cervical esophagostomy can be performed. Once weaned from the ventilator, tracheal resection and primary anastomosis, repair of the esophageal defect, and interposition of a muscle flap between the trachea and esophagus can be performed. So this picture is lifted from Schwartz, showing a single-stage operation for closure of TEF and tracheal resection. So basically, the fistula is divided here, and the trachea is transected below the level of the damage. The fistula is then closed in a single layer on the tracheal side and the esophageal side in a double layer. The damaged tracheal segment is then resected and reanastomosed. A muscle flap, such as the sternohyoid muscle, is then used to buttress the esophageal repair. The last one that should be done is the anastomosis of the trachea. So that's it for the trachea. Now let's proceed with the lung. So I believe you all saw this already from your anatomy class. This is basically how our lung looks like. The segmental, bronchial, and vascular anatomy of the lungs allows subsegmental and segmental resections if the clinical situation requires or if lung tissue can be preserved. That is the basic reason why they are divided into segments. It's for the resection. The lungs can be conveniently viewed as two linked components, the tracheobronchial tree and the alveolar spaces. The former is the conducting airways component, which consists of approximately 23 airway divisions to the level of the alveoli, and they are lined by pseudostratified ciliated columnar cells and mucous cells. The alveolar space, on the other hand, is the gas exchange component and is made up of type 1 and 2 pneumocytes. Now let's go to pre-invasive lesions. These are divided into three, and we shall discuss each. It is important to remember that these lesions constitute a clear marker for potential development of invasive cancer. So let's start with the squamous dysplasia and carcinoma in situ. Cigarette smoke induces transformation of the tracheobronchial epithelium to a metaplastic squamous mucosa. There is, in squamous dysplasia, there is altered cellular polarity, increased cell size, increase in the number of the cell layers, increased nucleus to cytoplasm ratio, and the number of mitoses increases as well. There are gradations here in squamous dysplasia. We have mild dysplasia, moderate dysplasia, and severe dysplasia. It depends on the characteristic of the cells involved. So, carcinoma in situ represents carcinoma that is still confined to the basement membrane. Next, we have an atypical adenomatous hyperplasia. These are lesions smaller than 5 millimeters. The epithelial cells lining the alveoli are similar to type 2 pneumocytes and are actually these are actually histologically similar to carcinoma in situ. A typical adenomatous hyperplasia actually represents the beginning stage of a stepwise evolution to adenocarcinoma in situ and then to adenocarcinoma. The lesions can be multiple, typically small, and have a ground glass appearance. The last recognized pre-invasive lesion is the diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. This is a rare lesion and defined as diffuse proliferation of neuroendocrine cells but without invasion of the basement membrane. Diffuse idiopathic pulmonary neuroendocrine cell hyperplasia can exist as a diffuse increase in the number of single neuroendocrine cells or as small lesions less than 5 millimeters in diameter. Carcinoid tumors are part of this pre-invasive lesion, but the, the carcinoid tumors are more than 5 millimeters in size, or they may be those that breach the basement membrane. So after the pre-invasive, we also have invasive lesions or the malignant ones. So it's basically divided for the lungs, it's divided into three. We have the non-small cell, the salivary gland type neoplasms, and the neuroendocrine neoplasms. For the non-small cell lung carcinoma, they are divided into adenocarcinoma, squamous cell, and large cell carcinoma. So let's start with NSCLC, the adenocarcinoma component. So, adenocarcinoma of the lung is the most common type of cancer, accounting for 30% of lung cancers in male smokers and 40% of lung cancer in female smokers. It has more preponderance to female than males. Adenocarcinoma is the most frequent histologic subtype in women, in patients less than 45 years of age, and in Asian populations. They have different histologic subs as mentioned below, uh, but we won't be delving on this further. It's just nice to know. These are all divided, the subtypes are all divided based on their molecular behavior and predominant histologic growth patterns. Next, we have a type of NSCLC, the squamous or squamous cell carcinoma. Squamous cell carcinoma represents 30 to 40% of all lung cancers and is the most frequent cancer in men. Squamous cell carcinoma is highly correlated with cigarette smoking. They arise primarily in the main lobar or first segmental bronchi. So these are collectively termed as central airways. So kasi nasa gitna. Symptoms of patients with squamous include cough, hemoptysis, wheezing, dyspnea, and pneumonia because there is a central obstruction due to the mass. Non-small cell lung carcinoma subtype, the last one is the large cell carcinoma. It occurs in 10 to 20% of all lung cancers and may be located centrally or peripherally. Large cell carcinoma cell types have diameters of 30 to 50 micrometers and are often admixed with various other malignant cell types. The next malignant lesion of the lung is the salivary gland type neoplasms. These neoplasms give rise to tumors that are histologically identical to those seen in the salivary glands. We have two, the adenoid cystic carcinoma and the mucoepidermoid carcinoma. Both of these occur centrally due to their site of origin. Adenoid cystic carcinoma is a slow-growing tumor that is locally and systemically invasive. They grow submucosally and infiltrate along the perineural sheaths. Mucoepidermoid carcinoma, on the other hand, consists of squamous and mucous cells and are graded as low or high grade depending on the mitotic rate and degree of necrosis. The last invasive lesion is the neuroendocrine neoplasm. Neuroendocrine lung tumors are classified into neuroendocrine hyperplasia and three grades of neuroendocrine carcinoma, with a grade 4 aptly called small cell lung carcinoma. We have tackled neuroendocrine hyperplasia previously in the pre-invasive lesion, right? So we start with neck grade 1, aptly called the classic or typical carcinoid. This is a low-grade neuroendocrine tumor arising in the central airway 80% of the time and occurring in younger patients. Grade 2 neuroendocrine tumor is um, also called a typical carcinoid. This has much higher malignant potential and is linked to cigarette smoking. As compared to grade 1, grade 2 is usually peripherally located. Next, grade 3 are the severe ones. These are large cell type tumors occurring in heavy smokers and are located in the mid to peripheral lung fields. The last one, the grade 4, is the small cell lung carcinoma and is the most malignant neuroendocrine neoplasm. This may occur in 25% of all lung cancers and they arise primarily in the central airways. Next, grade 4 or small cell lung carcinoma is the leading producer of paraneoplastic syndromes. So I don't know if you can see, but this is an algorithm lifted from Schwartz. It shows the diagnosis of for adenocarcinoma in small biopsies and or cytology. So you don't have to memorize this. It's just nice to know. The gist here is that biopsies are important to provide a clear diagnosis, and in lung cancer, ancillary panel and immunohistochemistry staining are important to clinch the diagnosis since the behavior of the different malignant lesions and their management differ. Now we have another entity that is quite common. This is what we call the solitary pulmonary nodule. Solitary pulmonary nodules are single, well circumscribed spherical lesions that are 3 centimeters or less in diameter. They are completely surrounded by normal aerated lung parenchyma. Majority of these are actually detected incidentally on chest X-ray and CT scan. The differential diagnosis for solitary pulmonary nodule are infectious causes, congenital neoplastic, inflammatory, vascular, and traumatic disorders. CT scan can provide findings that are characteristic of benign or malignant lesions. Benign lesions on CT scan usually have a small size. They have calcification within the nodule and they have stability over time. Calcification may be diffuse, solid, central, or laminated. Granulomatous infections such as TB can demonstrate the first three patterns, whereas the popcorn pattern is common in hamartomas. CT findings characteristic of malignancy include growth over time, increasing density on CT scan, size of greater than 3 centimeters. The edges are irregular or spiculated or lobulated. And we also have what we call a corona radiata sign, wherein there are fine linear strands extending 4 to 5 millimeters outward and appearing spiculated. This is another algorithm for the management of patients with solitary pulmonary nodule. So if stable, remember if stable for the past 2 years, there is no need to do intervention. But if it is increasing, the nodule is increasing based on the imaging that studies that you have done, then we have to assess the patient clinically and determine the risk of getting a cancer. So I did not delve in the facts on the management of lung cancer, because it's not warranted at your level. So if you have free time, you can read it in Schwartz, but it's not required for now. Let's proceed with spontaneous pneumothorax. SP, or spontaneous pneumothorax, is secondary to intrinsic abnormalities of the lung, and it can be classified as primary or secondary. Primary spontaneous pneumothorax, or PSP, is spontaneous pneumothorax without underlying disease. The most common cause is an apical subpleural bleb. This occurs more frequently in smokers and in males with tall, thin body habitus. Secondary spontaneous pneumothorax occurs in the setting of an underlying lung disease. So these patients usually have an emphysema, cystic fibrosis, AIDS. There is probably metastasis to the lungs, asthma, cancer, or infection. So there is a known cause for the pneumothorax. There is also a third type of pneumothorax, which we call a catamenial pneumothorax. This is a rare condition, occurs in the second to third decades in women, and usually occurs 72 hours of onset of menses, and is strongly correlated to endometriosis. So during menses, the patient gets pneumothorax. So treatment actually for all of this is usually CTT with a water seal bottle. So you have to check for every now and then for the presence of bubbles in the water seal bottle. So if there is persistence of leak for more than 3 days, then there is probably a leak, and you may provide the patient with an option to do VATS, or video assisted thoracoscopic surgery. and eventual resection of blood. So we're done with the lungs. Let's now proceed to the chest wall. Surgeons confronted with a patient with a chest wall mass must be cognizant that their approach to diagnosis and treatment has significant impact on the patient's chances for long-term survival. All chest wall tumors should be considered malignant until proven otherwise. Patients with chest wall tumors, regardless of etiology, typically complain of a slowly enlarging palpable mass in 50 to 70% of cases, chest wall pain in 25 to 50%, or both. Benign chest wall tumors tend to occur in younger patients with average of 26 years old, while malignant tumors tend to be found in older patients averaging 40 years old. And as mentioned, 50 to 80% of chest wall tumors are malignant, so we have to consider malignancy first in all chest wall tumors until there is a proven biopsy for it. So we have two algorithms here. Both of these are lifted from Schwartz. So the one on your left is an approach for evaluating chest wall masses when the clinical scenario is uncomplicated and initial imaging suggests a clear diagnosis. So clear-cut na siya, based on history pa lang or physical examination and plus your imaging, you can say with confidence na, this is like 80% chondroma or 80% osteoma. So you use this algorithm. The one on your right is an algorithm for unclear cases. So these ones would require a needle biopsy or an incisional biopsy prior to a wide surgical excision. Actually, both of them are require wide excision, but the one on your right requires biopsy first prior to wide excision. Most the reason for this is because we are suspecting for a malignancy and we don't want to have multiple surgeries on those conditions or diseases that are malignant, diba? Mas nice if one big surgery na lang for it. So there are several benign neoplasms mentioned in your book, so we'll just tackle a few of each. The first one is chondroma. This one is seen primarily in children and young adults, but they may occur in um, older patients. Chondroma usually occurs at the costochondral junction anteriorly. What we see on radiography is a lobulated and radiodense lesion, and they may have diffuse or focal calcifications. They may also displace the bony cortex without penetration. Treatment for this is surgical resection with 2 centimeter margins. The next one is fibrous dysplasia. This most frequently occurs, again, in young adults, and they may be associated with trauma. So, diba, usually young people ang benign neoplasms. Contrary to chondroma, fibrodysplasia occurs at the posterolateral aspect of the rib cage. On radiography, we can see an expansile mass with cortical thinning, and there is also no calcification. Treatment is surgical resection with 2 centimeter margins. Another benign neoplasm is osteochondroma. This is the most common benign bone tumor and usually occurs in the first 2 decades of life. In the thorax, if osteochondroma occurs in the thorax, it usually arises from the rib cortex. Osteochondroma may be part of the syndrome hereditary multiple exostosis. So, if the patient has this kind of syndrome and the patient has an osteochondroma, the osteochondroma has a high rate of degeneration into a chondrosarcoma. So treatment for osteochondroma is local excision. Um, if you napansin nyo a while ago, for benign neoplasms, it's usually a 2 centimeter margin. But if deemed malignant, like if there is a component of a chondrosarcoma, we may do wide excision with a 4 centimeter margin. The fourth benign neoplasm mentioned in your book is eosinophilic granuloma. These are benign osteolytic lesions which may occur as solitary lesion, or this may be a part of the disease process called Langerhans cell histiocytosis. So in LCH, the involved tissue is infiltrated with large numbers of histiocytes which are often organized as granulomas. LCH is diagnosed primarily in children between 5 to 15 years of age, and most of the time healing occurs spontaneously. But if um, you have resources, the treatment is limited surgical resection with a 2 centimeter margin. And we also have desmoid tumors. These are soft tissue neoplasms arising from the fascial or the musculoaponeurotic structures. So as compared to the previous benign neoplasm, mostly coming from the bony cortex or on the costochondral junction, the desmoid tumors are soft tissue tumors. They consist of proliferations of benign appearing fibroblastic cells, abundant collagen, and few mitosis. This is common in patients in their third to fourth decade of life. They do not metastasize, however, they have the propensity to recur locally in 5 to 50% of cases. So if the lesion is above 3 or 4 centimeters, so let's say just the cutoff is 3 centimeters, then we have to do incision biopsy to rule out any form of malignancy. So wide local excision pa rin ang treatment, 2 centimeter margin if it's benign, 4 centimeter margin if there is a malignant component. We should also perform an intraoperative frozen section of the margins and eventual chest wall reconstruction because 4 centimeter margin is quite big. So um, this is where the plastic surgeons come in. So survival is good after wide local excision. If the margins are negative, it can be as high as 90% at 10 years. So from benign neoplasms, we go to malignant chest wall neoplasms. Chondrosarcoma is the most common primary chest wall malignancy. So as with chondroma, they also occur anteriorly at the costochondral junction. Most are slow-growing, low-grade tumors that can reach massive proportions. So, as with all other tumors, treatment is wide resection with a 4 centimeter margin. After metastasis has to be ruled out. So, there is no role for surgery or the role of surgery is limited if there is already metastasis. It is important to note that chondrosarcoma is not sensitive to radiation or chemotherapy. So, surgery lang talaga ang treatment. So, progress is determined by the tumor grade and the extent of resection. If the tumor is low grade and we performed a wide resection, patients survive 5 to 10 years can be as high as 60 to 80%. So, although this is a sarcoma, a neoplasm, the good thing about this is most are low grade. So we can have a higher survival rate if we perform the surgery correctly. Next is osteosarcoma. So this is the most common bone malignancy, but they represent only 10 to 15% of all malignant chest wall tumors. So this is not a common chest wall tumor, but this can occur. Osteosarcoma primarily occurs in young adults as a rapidly enlarging painful mass. Geography would show spicules of new periosteal bone formation, forming a sunburst appearance. So that's the sunburst appearance is very pathognomonic for osteosarcoma. Osteosarcoma has a propensity to spread to the lungs, and um, one third of patients actually present with metastatic disease already. So stage 4 na upon presentation. Since osteosarcoma is potentially sensitive to chemotherapy, we may um, do induction chemotherapy first, and then after that we do complete resection with wide margins, and of course reconstruction. So post-operatively, chemotherapy may also be given for osteosarcoma patients. Next, we have malignant fibrous um, histiocytoma. These neoplasms originate from fibroblasts. This is the most common soft tissue sarcoma of late adult life, but they are rare on the chest wall. So most common lang sa late adults. So typical age of presentation 50 to 70 years age. So radiographically we see a mass. The mass is evident. There is also um, destruction of the surrounding tissue and bone. Treatment is wide resection with margins of 4 centimeters or more with reconstruction. The downside for this is two-thirds of patients suffer from distant metastasis or local recurrence even after wide resection. So this is quite an aggressive tumor. We also have liposarcoma. They make up 15% of all the chest wall sarcomas. Most are low grade, but even if it is low grade, they have a propensity to recur locally. So liposarc, similar presentation as lipoma, so painless mass. Treatment, we will just know through histology na lang na, this is a liposarcoma, this is not a lipoma. Treatment is wide resection and reconstruction with intraoperative frozen section of margins. And we also have fibrosarcoma. This is a large painful mass visible on chest x-ray or CT scan with surrounding tissues destruction. So similar to other neoplasms, treatment is wide local excision with intraoperative frozen section of margins. The downside of fibrosarc is that it the the local recurrence and the systemic recurrence is frequent. So survival is only 50 to 60% in 5 years. So I think this is the last one discussed in your book, rhabdomyosarcoma. This is a rare tumor of the chest wall. And what we see microscopically when we encounter rhabdomyosarcoma are spindle cell tumors. The diagnosis often depends on immunohistochemistry staining for muscle markers. And this condition is sensitive to chemotherapy. So we provide preoperative chemotherapy first and then subsequent surgical resection for these types of patients. So now let's go to the mediastinum. The mediastinum is divided into compartments for classification of anatomic components and disease processes. The anterior compartment lies between the sternum and the anterior surface of the heart and great vessels. The middle compartment is between the great vessels and the trachea, so this includes also your heart. While the posterior compartment is everything that lies posterior. So this includes both paravertebral sulci and the paraesophageal area. So both these tables again are lifted from your book, Schwartz. I want to show you this table because these are the common tumors occurring in the mediastinum based on their location in the compartment. So it is important to note that, so first we have thymoma. Thymoma is the most frequently encountered neoplasm of the anterior mediastinum in adults, but this is rare in children. So, thymoma is strongly correlated with myasthenia gravis or MG. So, but only 10 to 15 patients with thymoma have myasthenia gravis. Conversely, less than 10% of patients with myasthenia gravis have thymoma. The diagnosis is usually based on MRI and PE as well as CT scan. The most commonly accepted staging system for thymoma is the Masayoka staging system. So, stage 1 has no gross evidence of capsular invasion. So, usually kasi thymoma, when you remove it, at diba, the treatment is complete removal. So, we usually do sternotomy, midline sternotomy, although VATS is increasingly being used here, especially in Cebu nowadays, to to remove the tumor. Um, Commonly, ano pa rin, open surgery. So, tumor is encapsulated, no gross invasion. So, that's stage 1. Number 2, stage 2, gross invasion of the capsule or into the mediastinal fat, or into the pleura, or if there is microscopic capsular invasion. Stage 3, there is invasion into the pericardium, great vessels, or the lung. Stage 4A, pleural or pericardial dissemination, and stage 4B, we have lymphogenous or hematogenous metastasis. Next, we have neurogenic tumors. Um, these tumors arise from either nerve sheath, from ganglion cells, or from the paraganglionic system. So the incidence, the cell types, the risk of malignancy strongly correlate with patient age. So these are the classification of neurogenic tumors in the mediastinum based on the origin of tumor. So for nerve sheath, we have benign tumors, neurilemoma and neurifibroma, which are the two most common. If we are talking about malignancy, we have neurofibrosarcoma. Ganglion cell tumors, benign ganglioneuroma, malignant ganglioneuroblastoma. And for the paraganglionic cells, we have chemodectoma and pheochromocytoma. So we shall not be discussing each of these. Nice to know lang at your level. So this will be the last neoplasm I will be discussing under the mediastinum. Lymphoma is the most common malignancy of the mediastinum. So this is not to be um, confused with thymoma. Thymoma is the most common malignancy in the anterior mediastinum. The most common malignancy overall is lymphoma. Primary site, that's 50% kids. 50% of patients who have both Hodgkin and non-Hodgkin lymphoma. The primary site is the anterior compartment. Primary site is the mediastinum, and the anterior compartment is most commonly involved. So, treatment for lymphoma is actually medical. Chemotherapy, sometimes radiation. So, cure rate is up to 90%. Surgery only has a limit lymphoma except when you perform biopsy. So, cure rate is 90% for patients with early stage Hodgkin disease and 60% with those with more advanced stages. I think this is the last two slides. So, pleura and the pleural space. So, the pleura is the mesothelial lining that invaginates at the hilum of each lung and continues on to cover each lung. So, pleura is divided into two, parietal and visceral. So, parietal pleura is the portion lining the rib cage, the mediastinum, and the diaphragm. And the one that encases the lung is the visceral pleura. The parietal pleura is very rich in somatic innervation and there is also sympathetic parasympathetic innervation. So the patients, if the parietal pleura is irritated, such as in cases of infection, there is pneumonia, or there are masses, so you experience a form of a chest wall pain. Visceral pleura naman, there is no somatic innervation, so you don't feel anything even if there is ongoing infection there. So between the two pleuras, we have what we call the postural pleural space. So this is the area where you get your effusion, dito tumutubo yung masses. So I'll just discuss the pleural effusion lang in general. Pleural effusion is any significant collection of fluid within the pleural space. So normally, we produce fluid in the pleura around 5 to 10 liters. This is from filtration through the microvessels kasi di ba may mga capillaries and everything. So 5 to 10 liters per day. But the normal amount of fluid present at any given time is 15 to 20 milliliters. So that's the normal pleural fluid present. But once there is disturbance in the forces between the capillary flow and the pulmonary circulation, there is imbalance and accumulation of pleural fluid. So this commonly occurs. There is an insult or an injury to the pleura. So infection, masses, may mga trauma, nagkakaroon ng imbalance and eventually pleural fluid. So treatment differs depending on the cause of injury. So we can do diuresis, thoracentesis, or CTT. So diuresis, very common if like the cause is CHF, congestive heart failure. So hindi not naman like required talaga mag CTT for CHF unless it's very very taas na ba ang water levels. But even then, we just do thoracentesis for patients with CHF, and then we just diurese and diurese. Diuresis is actually for patients with minimal effusion and resolving pneumonia. Siguro mga 1 to 2 ribs lang na blunting or blunted lang ang costophrenic sulci or costophrenic angle, then we may do diuresis. Sometimes na we don't even do that. We just give the patient antibiotics, and then when the pneumonia resolves, the pleural effusion will also resolve naman eventually. Thoracentesis, so this is usually for high-risk patients that cannot undergo CTT. So maraming mga conditions. So very high comorbidities. We just use thoracentesis on them. And it's important that the effusion is non-loculated. Kasi if loculated, automatically we go for CTT. So this is actually the definitive diagnosis and actually treatment for effusion. If we also encounter empyema or chylothorax is the presence of chyle on the pleural space. So automatic CTT yan. So that's it. We shall not delve deeper into empyema, chylothorax. You may read that on your spare time. Ends our chapter. Very short lang. So you may study after this and then post test after.